the effects of diabetes in retina. My explanation about diabetic retinopathy will be pretty much brief and in making it sure in point of how a physician or how a gynecologist should deal will be my most concern.
Okay, yeah. Let me introduce.
First, let's begin with how a normal retina looks like in a
Kavya?
Sorry?
Excuse me, Kavya. We'll introduce, and Dr. Dwaraknath Reddy sir is here to inaugurate the session. Just give me 1 minute. Okay?
Okay.
Yeah. Good evening to you. Good evening to you all. I am Dr. Vasantha Kumari, Chairman, Scientific Committee, Telangana IMA. I cordially invite you all for today's Wednesday's webinars on diabetic retinopathy by Dr. Kavya Rao from Center for Sight, Chella Eye Care, Hyderabad. I request Dr. Pranusha to introduce the speaker for today's webinar. Dr. Pranusha is ophthalmologic retina surgeon from Nalgonda, Netra Eye Care. She is graduated from Sarojini Devi Eye Hospital, Usmania Medical College, and she has done her fellowship from Shankara Eye Hospital, Bangalore. Over to you, Dr. Pranusha.
Thanks a lot, ma'am. Thank you for the great opportunity. So today we are going to discuss about the most dreadful disease and which is also preventable blindness, which is the most common cause of preventable blindness in India or throughout the world. That is none other than diabetic retinopathy. So I want to introduce the esteemed doctor, Dr. J. Kavya Rao, who is a consultant from...
Dr. Pranusha?
Yes, ma'am.
1 minute, ma, sorry. I request Dr. Dwaraknath Reddy sir, IMS President-elect, requesting him to inaugurate the webinar on diabetic retinopathy today. This is our third webinar since June, sir. As a scientific chairman, along with our co-chairman, Dr. Srirang Apkari, and convener, Dr. Sampath, I am able to do this third program successfully. Over to you, Dr. Dwaraknath Reddy sir.
Yeah, good evening, Vasantha and team. I think it's a really wonderful occasion that you are conducting these webinars in a regular manner, and that too of important, taking important subjects. So this particular subject of diabetic retinopathy is a very important subject, and I think it is a sort of a preventable thing that if they follow certain of the all the follow instructions and all. I congratulate Vasantha and the entire team of the scientific committee for taking this regularly organizing these webinars on a constant basis. And whatever the COVID has shown us, I think this is one thing that could happen during COVID and post-COVID, that we are meeting like this on important webinars on a regular basis. And I once again congratulate the entire team, and also my congratulations goes to Dr. Kavya Rao presenting this particular important topic and bringing all the aspects related to the diabetic retinopathy. I thank once again, and I now request Dr. Vasantha to take over and start the proceedings in regard to the webinar. Thank you very much.
Thank you very much, sir. I request Dr. Pranusha to introduce today's speaker, Dr. Kavya Rao.
Okay, ma'am. Yeah. So today, Dr. J. Kavya Rao is in front of us to give a very valuable lecture on diabetic retinopathy. She has graduated from Kamineni Institute of Medical Sciences, MS from Medicity Institute, and she has done from fellowship from an esteemed LV Prasad Eye Institute, Medical Retina Fellowship, followed by Vitreoretina Surgical Fellowship at Lions Club of Hyderabad. And she also trained herself in retinopathy of prematurity from LV Prasad Eye Institute. Currently, she is working as a vitreoretina consultant at Center for Sight, Challa Eye Care. So over to you, ma'am. Please.
Okay. Thank you, Dr. Pranusha and Dr. Vasantha Kumari, madam. So I will begin my slides now. Okay. So I'll just give a brief introduction of how a normal retina should be like. In a well-dilated pupil of 8 mm in size, the retinal glow or the fundal glow, if it is orangish or reddish in color, it signifies a healthy retina. If an imaginary line is drawn vertically and horizontally, it is divided into 4 quadrants, that is superior, inferior, nasal, and temporal. The optic nerve, which is present towards the right side, represents the right eye. And if it is present to the left side, it represents the left eye. And the 4 major blood vessels, they bifurcate from the optic nerve head, and they divide into superior, inferior, nasal, and temporal. These major blood vessels, they are the branch of ophthalmic artery, which is in turn the first branch of internal carotid artery. These blood vessels are central retinal artery and central retinal vein. Once they bifurcate and they divide branches, it forms into branch retinal artery and branch retinal vein. The central part of the retina, which is called as a macula, which is a reddish in color, it is a avascular zone, and the best part of the vision comes from this part of the macula. Now, optical coherence tomography, it is an imaging, non-invasive imaging modality, which uses low coherence interferometry to produce this cross-sectional images of the retina. Now here we see the darkmost part, which is the vitreous. Vitreous is nothing but the gel which is present above the retina. And the retina, which has 10 different layers, it is representing in the scan as hyper and hyporeflectivity. The outermost being the retinal pigment epithelium. Below that we have choroid, and the outermost is the sclera, or the white part which we see. The epidemiology. Diabetic retinopathy is a major cause of preventable blindness in the world, of which the diabetic macular edema is the most common cause of moderate vision loss in patients with diabetic retinopathy. The prevalence in India is between 7.3 to 25%. The Diabetic Control and Complications Trial reported an incidence of 54.2% of diabetic retinopathy in patients with type 1 diabetes. The 9th edition of Diabetic Atlas by IDF, which was released in 2019, they have shown that 463 million people with diabetes are there in the world, and this number may shoot up to 700 million by the year 2045. The risk factors associated are type 1 diabetes, which are 2 times risk for diabetic retinopathy because of the insulin dependent, and glycosylated hemoglobin, which is more than 7%, nephropathy, dyslipidemia, pregnancy, smoking, and obesity. Now, because of hyperglycemia, there is abnormalities in the metabolic pathway, the polyol pathway wherein the glucose is reduced to sorbitol and which should then be converted to fructose. The sorbitol is because of the impermeability of the sorbitol, it gets accumulated in the endothelial cells and causes damages. Chronic hyperglycemia also causes accumulation of advanced glycated end products and protein kinase C overaction. This protein kinase C activation causes capillary occlusions and causes upregulation of vascular endothelial growth factors. This vascular endothelial growth factors are produced by the retinal cells, that is nothing but the Muller cells, glial cells, and the retinal pigment epithelial cells. So what is happening is because of the chronic oxidative stress, it causes a lot of endothelial cell loss and pericyte loss, by which the blood retinal barrier disruption is occurring. In retina, blood retinal barrier is of 2 types, that is the outer and the inner blood retinal barrier. The outer blood retinal barrier being the retinal pigment epithelium, or the outermost layer, and the inner blood retinal barrier is the tight endothelial cells. So now, because of the impairment of the blood flow, hypoxia, release of vascular endothelial growth factors, there is blood retinal barrier disruption, and that's leading to the egress of the fluid into the intraretinal layers, causing a diabetic macular edema. Now, parallelly, because of a lot of hypoxia, there is retinal ischemia, by which there is release of hypoxia-induced factor alpha 1 and insulin-like growth factors, all of which contributes to the formation of retinal neovascularization, which can be, the neovascularization can be occurring at the optic nerve head or elsewhere, leading to proliferative diabetic retinopathy and further complications. The symptoms of diabetic retinopathy we have is a gradual worsening of the vision, or they can present with a sudden vision loss, wherein it indicates that the eye has advanced much severe that it has led to a vitreous hemorrhage. Shapes floating in the field of vision, which is nothing but floaters. Now, according to the early treatment diabetic retinopathy study, basing upon the clinical signs and the findings that are present in the retina, it is divided into non-proliferative and proliferative diabetic retinopathy. The non-proliferative one is again divided into very mild to moderate, severe. Again, these are being graded according to the dot plot hemorrhages, the cotton wool spots, and the vascular changes. The proliferative diabetic retinopathy is again having neovascularization, or if it has high risk characteristics such as a vitreous hemorrhage, or if there is any tractional detachments. The clinical significant macular edema, it is a form of diabetic macular edema, which was defined by ETDRS as having one of the following criteria being met. That is retinal thickening within 500 millimicrons of the center of the macula, hard exudates or within 500 millimicrons of the center of the macula, retinal thickening 1 disc area or larger, any part of which is within 1 disc diameter of the center of the macula. These are the photographs which have been showing the mild, moderate, severe forms of non-proliferative diabetic retinopathy. These have been graded again basing on the number of hemorrhages present in each quadrant, number of cotton wool spots, presence of vascular abnormalities such as venous bleeding or looping, and the high-risk proliferative presence of a vitreous hemorrhage or neovascularization. The tractional retinal detachment, which is an advanced diabetic eye disease, which is nothing but a vision-threatening diabetic retinopathy. It is basically called vision-threatening because even the macula is also involved along with the scarring that is occurring. Now, at this phase, if surgery is still left without any surgery, this is the traction which can cause a pull over the retina, and it can cause a big break or a hole, which is called as a regmatogenous detachment. So a combination of tractional retinal detachment and regmatogenous retinal detachment can occur in worst cases. Now, again, the diabetic macular edema is being divided as mild, moderate, and severe, basing on a amount of retinal thickening, the hard exudates that are present in the posterior pole, and presence of hemorrhages. The posterior pole is nothing but the one which is above and below that of the uh, yeah.
Everybody, please turn off their microphone. Thank you.
Now, according to the OCT patterns, it is divided into 5 different types. That is the diffuse, wherein it is called as dissociation of the retinal inner layers. And also there are presence of hyperreflective dots, which is mainly indicative of a poor OCT biomarker and a poor visual prognosis. And then we have the cystoid or the spongy spaces, which is nothing but hyperreflective areas present in the outer plexiform layer. The serous retinal detachment, a combination of cystoid spaces and a serous detachment, which is called as a mixed. And then we have is a vitreomacular traction, wherein the thick posterior hyaloid acts over the macula, and thus causing a pull along with cystoid spaces and serous retinal detachment. The two imaging modalities we have is the fundus angiography and the OCT angiography. The fundus angiography, wherein it is an invasive imaging modality, the fundus fluorescein dye, which is either the dose of 5 ml of 10% or 10 ml of 5% fluorescein dye, it is injected into the anterior cubital vein after 5 to 6 hours of minimal fasting, and a series of images are being taken out, starting with the pre-arterial, venous phase and the late and recirculation phase. The entire phase should be completed in under 10 minutes. And wherever the areas of a well-perfused area or a poorly perfused retina is being visible, if there is a presence of a neovascularization, they will show hyperfluorescence with the presence of a leakage. Now, OCT angiography, which is a relatively a newer one, wherein it does not require any dye injection, which is pretty much beneficial to the pregnant woman, especially in the first trimester. And it also shows the presence of perfusion, a well-perfused area, or the presence of the dark areas, which signifies an ischemic retina or poor circulation of the retina. So OCT angio, while FFA is a gold standard for diagnosing diabetic retinopathy, Opta may be able to do so as well. It serves as an alternative non-invasive method to FFA and predict the visual prognosis. Now, the baseline diabetic profile test that can be conducted by any ophthalmologist is CBP with ESR, fasting and postprandial blood sugar, glycosylated hemoglobin, fasting lipid profile, blood urea, and serum creatinine. The treatment of diabetic retinopathy should be, first stage is to be controlling the systemic risk factors. And then the next line of treatment, if there is a presence of a macular edema, wherein we give anti-VEGF injections, which is the first line of treatment. Next, we have corticosteroids and the laser. And in the advanced diabetic eye conditions, wherein there is a tractional detachment, surgery is the only resort. Now, the diabetic control and complications trial. The tight control of blood glucose level leads to the reduction of risk of progression of diabetic retinopathy by 54%, reduced development of a severe NPDR or a PDR by 47%, 56% risk reduction in the need for laser, and 23% risk reduction in the development of diabetic macular edema. Now, the anti-VEGFs, vascular endothelial growth factor is a member of platelet-derived growth factor. Binding of VEGF with its receptors, leading to endothelial cell proliferation and new vessel growth formation, and causes angiogenesis. Now, what anti-VEGF drugs do is it prevents the binding of VEGF-A to its own receptors and reducing the activity of neovascularization. The commonly used drugs we have is ranibizumab, bevacizumab, and aflibercept. Now, after giving the injections, the most common complications we receive is the intraocular pressure spike, vitreous hemorrhage, subconjunctival hemorrhage, tegmatogenous retinal detachment, and worsening of the traction over the macula if given in patients with tractional detachments. The corticosteroids, which serve as a second-line drug of treatment for diabetic macular edema, it mainly reduces the edema by decreasing the leukocyte migration and pro-inflammatory cytokines. It causes downregulation of intercellular adhesion molecule 1 expression. Now, from anti-VEGFs to an intravitreal steroids also can be switched in certain conditions wherein in pseudophakic patients who have reached a phase where there is persistent intraretinal fluid in spite of multiple anti-VEGF injections, or when the vision is less than 6/12 and it is not improving further. Occurrence of any systemic vascular event like any cardiac issues while on anti-VEGFs, and associated features such as presence of hyperreflective dots on OCT, as I mentioned earlier. The currently available steroid injections are triamcinolone acetonide, dexamethasone implant, and fluocinolone insert. Dexamethasone, which is commonly available in the trade name of Ozurdex, it is approved by FDA in 2009. It is a biodegradable polymer and provides sustained release of the drug, which is about 700 mcg. It is implanted with a 22 gauge applicator, and the applicator has a side knob over here. Once the 22 gauge is inserted inside of the retina, and then the knob has to be clicked, wherein the implant will go inside the vitreous cavity, and the presence of the implant has to be seen immediately under the dilated pupil. Now, the treatment for non-center involving diabetic macular edema and center involving. Non-center involving, I mean to say that if the edema is there, but it is not involving the macula and it is outside of the macula and in the posterior pole, in such conditions, if the vision is good between 6/6 to 6/9, then you can just monthly observe. But if the vision drops to 6/9, then you can plan for a focal laser as it is outside of the macula. Now, the center involving the mainstay of treatment will be anti-VEGF agents. So there have been multiple clinical trials demonstrating that anti-VEGF therapy is more effective in improving vision in center involving diabetic macular edema than the laser itself, making it a first-line therapy. The laser. The laser has been accepted form of treatment worldwide after recommendation by ETDRS. The type of laser used is argon green laser with a wavelength of 514 nanometers. So the main mechanism here is the laser. It mainly helps in relieving the hypoxia and by making the retina anoxic. So the laser spots which have been visible in this picture here is been conducted in 2 or 3 sessions and covering entire part of the retina outside that of the posterior pole. The posterior pole is nothing but the superior and inferior arcades. Inside of that is posterior pole. Now, for those patients who have macular edema along with a cataract, in such cases, first the diabetic macular edema should be stabilized and then plan for a cataract surgery. But if the cataract is very dense and then there's a poor visibility of the fundus, in such cases, the cataract surgery should be done and along with it, plan to give an injection of anti-VEGF. The patient should be counseled on the visual outcome following cataract surgery, as the vision may not be as good as those without diabetic retinopathy. Certain few recent advances in management of diabetic retinopathy. The first drug is the faricimab, which is a monoclonal antibody and it's targeted against the VEGF-A and angiopoietin-2. It has gotten FDA approval in Jan 2022 and its dose is about 0.05 ml or 6 milligram. It is available in the market in the trade name of Vabysmo. Brolucizumab is another strong anti-VEGF drug, which is a single-chain antibody fragment inhibitor. It has got an FDA approval in September 2021, and the dose is again same 0.05 ml or 6 milligram. Now, Chakrabarti et al. Have demonstrated excellent results with recalcitrant DME. The port delivery system with ranibizumab, the long-acting drug delivery system that enables sustained delivery of a formulation of ranibizumab into the vitreous cavity. It has a permanent refillable implant that is surgically inserted through the small incision in the sclera, which has been approved by FDA in 2021 October. This is an 8 mm length and a 4 mm wide port delivery drug, which is inserted into that of the vitreous cavity. And those patients who require monthly injections for a long period of time, this is much efficient for them as it can reduce the risk of vitreous hemorrhage or inadvertent retinal detachments. The next one or the most recent advance is the fenofibrate, which is a peroxisome proliferator activated receptor alpha, a transcription factor which is mainly used for controlling the cholesterol. An oral dose of 145 milligram daily is being studied, and it has been shown that it has vasodilatory, anti-inflammatory, anti-apoptotic properties that may be beneficial for diabetic retinopathy. The two studies which are still under trial are Field and Accord. Now, certain length of protocols have been there in diabetic retinopathy, which have been studied by Diabetic Retinopathy Clinic Research Network. They're from protocol A to W. And among all of these protocols, protocol S, T, U, and V are most beneficial. More beneficial for the clinicians. Protocol S, which shows that during a proliferative diabetic retinopathy, either laser or an injection should work. And they have found out that the injection, that is ranibizumab or anti-VEGF, it is not inferior. Protocol T, wherein it studied the drugs of 3 anti-VEGF agents for diabetic macular edema. And they found that all the 3 anti-VEGF drugs are very effective, but aflibercept has an upper hand. The protocol U, wherein it shows a combination of steroid and anti-VEGFs for center involving diabetic macular edema after just single anti-VEGF therapy. And they found out no difference in it. And the last one, the most important, is the protocol V, wherein the treatment for center involved diabetic macular edema in eyes with very good visual acuity. And they found there was no significant visual loss if it is managed via injection, laser, or you can just observe. Now, and they found out that 12.5% of the people with diabetes had diabetic retinopathy, and 4% of them had vision-threatening diabetic retinopathy. Unfortunately, in the early stages of diabetic retinopathy, that is very mild, mild, or mild moderate, they're usually asymptomatic. But once the macular edema sets in moderate or very severe, it is usually not completely reversible. Therefore, it is crucial to screen for diabetic retinopathy after 2 to 5 years in type 1 diabetes. The recommended screening guidelines we have is, in the case of people who are diagnosed with very mild, moderate diabetic retinopathy, the screening should be done at least yearly once. For the ones who have moderate or severe and very severe, they have to be screened every 4 to 6 months. And for those who have very severe, at least 2 to 3 months of screening. Now, in the proliferative types, for those who have mild, moderate, or high risk characteristics such as the neovascularization, wherever laser or any injections are to be done, a monthly follow-up is typically advisable. And for those who are suffering with a vitreous hemorrhage or a tractional retinal detachment who require surgery, then surgery is the only stay. A brief about a vitrectomy and how a retina surgery is performed. The 3 ports are being placed into the retina. The infusion cannula, wherein it has to be substituted with the vitreous gel, and a fiber optic light probe is being passed, and then a vitreous cutter is being there, which helps to eliminate the vitreous hemorrhage or any fibrovascular proliferations or any tractions around her. Now, the patients who have a cardiovascular disease and they have a diabetic macular edema, in such cases, it is better to avoid anti-VEGF drugs. Instead, plan for a steroid injection, or if it is a proliferative condition, plan for a pan-retinal photocoagulation. Now, diabetic macular edema in pregnancy. Very little is known regarding the management of macular edema in pregnancy. It has been reported that it regresses after delivery. If there is progressive deterioration of vision, the use of intravitreal steroids or dexamethasone implants are recommended in 2nd or 3rd trimester. Anti-VEGFs are not recommended in pregnancy because of teratogenic effects on the fetus. Chan et al. Advised early use of laser in proliferative diabetic retinopathy during pregnancy instead of waiting for spontaneous regression, as that might give a worse outcome. Now, how do we screen for diabetic retinopathy in pregnant women? Pregnancy is known to worsen diabetic retinopathy in women with type 1 diabetes with prevalence between 34 to 72% and compared to type 2 diabetes with a prevalence of 14%. The first screening is to be done at 13th week. The second screening is done at 16 to 20 weeks and the third screening at 28 weeks. Now, if a woman is planning for pregnancy and if she is diabetic, then prior to conception also, the fundus examination is to be done. Now, during pregnancy, those pregnant women with mild or mild NP or non-proliferative diabetic retinopathy, they have to be screened in the first and the last trimester. And those with a mild, moderate, proliferative, non-proliferative diabetic retinopathy, they have to be screened at every trimester. And those who have severe or proliferative conditions, they have to be screened every month. Now, post-pregnancy or post-delivery, the dilated retinal examination should be considered 1 to 2 months after delivery in women with treated or untreated diabetic macular edema, and those with mild, moderate, or severe non-proliferative retinopathy during pregnancy and followed up until 12 months to 1 year. Now, the screening in the pediatric age group. According to International Society of Pediatric and Adolescent Diabetes, those who have type 1 diabetes, they have to be screened after the 11 years of age with 2 to 5 years of duration of diabetes. So this framework allows identification of any signs of retinopathy. The role of physicians in diabetic retinopathy screening, it is very important that the physicians or the clinicians, they are supposed to send their patients for a diabetic retinopathy screening. And also, it's important to educate the diabetic patients visiting the clinics regarding various complications of diabetes like heart failure, neuropathy, nephropathy, including in retinopathy requiring regular screening to avoid permanent loss of vision. Now, the role of portable or non-portable fundus cameras using artificial intelligence. Now, artificial intelligence in the TopCon fundus camera was able to grade the severity and generate the report. It also helps the physician that can advise the patient accordingly. The main purpose of the screening and automated or the AI is to alert the patients in the case of evidence of diabetic retinopathy so that further management can be taken by an ophthalmologist. all this is done just to prevent the loss of vision. A community-based screening. Now, NGOs, diabetic clinics, corporate offices, etc., they all have conducted an annual health checks. In that annual health checks, even diabetic retinopathy also should be included as a part of the package. Now, All India Ophthalmological Society Task Force Committee and Vitreoretina Society screening for individuals with known diabetes who are receiving treatment and have an RBS of more than 200 milligram per deciliter or glycosylated hemoglobin of more than 6.5%. Now, government has launched recently a program called Ayushman Bharat Pradhan Mantri Jan Arogya Yojana, wherein it is a center and state co-sponsored health insurance scheme, providing health services as per packages to about 500 million people. This is implemented by the National Health Authority. In April 2022, NHA has released health benefit packages, which includes the diabetic retinopathy package also, which includes vision, refraction, fundus photo, and the scanning, that is optical coherence tomography. Now, we have to create public awareness for diabetic retinopathy, which is very important. This can be done in forms of clinic posters, patient education materials through media, patient education posters in the waiting areas, and spreading awareness about diabetic retinopathy and preventing blindness. The ways to reduce the risk of diabetic retinopathy is by controlling the blood sugars, blood pressure, cholesterol, and any other cardiac issues, taking the diabetic pills and meeting the clinicians on time, attending to all follow-up timely appointments, getting medical advice quickly if you notice any changes to your vision, and maintaining a healthy diet, eating a healthy, balanced food, exercise regularly, and to stop smoking. I thank everybody for this. I hope it was very brief and very clear to everyone. Thank you.
Thanks a lot, ma'am. It was a very, very, very beautiful presentation on diabetic retinopathy. You have covered all the important topics of DR, the screening protocols and the protocols in pregnancy and the treatment. Thanks a lot, ma'am. So DR is preventable through strict glycemic control and which requires annual dilated examination, which is never done in a mid-dilated or undilated pupils. So many of the people with diabetic retinopathy, we could see peripheral diabetic retinopathy, which we could not see with the undilated pupils. One more thing, we have to differentiate between non-proliferative and proliferative diabetic retinopathy. So this can be easily done if we are in doubt with a red-free filter. So the vessels will highlight if we use red-free filters. So in diabetic retinopathy, along with the ophthalmologist, physicians and nephrologists also play a very key role. One more thing, so proliferative diabetic retinopathy, usually in case of type 1 diabetes, the onset is very earlier. Whereas diabetic macular edema, the onset will be earlier in case of type 2 diabetes. So, ma'am, can you answer the things which are mentioned in the chat box?
Yeah. Any relation with age-related macular degeneration and how to delay diabetic retinopathy? So, age-related macular degeneration, it has not much of correlation with diabetic retinopathy as far as I know of.
Madam, namaste, madam. I am Dr. Mathur, physician.
Cheppan, sir.
What was the cost, madam, vascular endothelial growth factor? Madam, how many sitting and which one is the best one? As you said, I'm hearing.
Yeah.
So the patient follow up, how many months or days, how many days you are advising, madam?
Okay. So in general, among the three anti-VEGF drugs that I have mentioned, nowadays the best injection that people can prefer is aflibercept. They can give even a ranibizumab also. among anti-VEGF agents. But the latest drug, that is brolucizumab, even that has showing a lot of beneficial results. So even patients can prefer those as the first choice of drugs also. And basing upon the how much of clinical signs we are seeing in the fundus, that is according to the number of hemorrhages and number of cotton wool spots and all, we basing on that we take a call whether it has to be 6 months or it has to be 1 year. If there are no absolute any changes of diabetic retinopathy in the retina, then I usually call yearly once. If there are any significant amount of there is an macular edema, significant macular edema, then after giving an injections, I would give a monthly follow-ups. And once the macular edema is stabilized and macula is completely dry, then again, I would extend my follow-ups. Instead of monthly follow-up, I would make it once in 2 months and then 4 months and then 6 months and so on.
Preferably which stage, madam? Preferably proliferative or non-proliferative, madam?
Which
Stages of diabetic retinopathy people are preferring, madam, for vascular endothelial growth factor.
The injections. So,
Yeah,
sir,
yeah.
injections can occur in a non-proliferative and proliferative also. So, in a non-proliferative also, we see macular edema, and in proliferative also, we see macular edema. So, in both the stages, we can give injection unless there is any vision-threatening factor, like, if there is any attractional component or something like that. In that cases, we do not give any injections. We can plan for a laser instead. But if the traction is again worsening and the macula is also threatening, then even laser won't work and directly they have to plan for a surgery.
Thank you, madam. Thank you, madam.
Yeah.
Thanks a lot, ma'am.
Yeah.
So any other queries from the audience?
Good evening, madam.
Good evening, sir.
I am Dr. Rajshekhar, one of the physicians in Nalgonda, madam.
Okay, sir.
See, I just wanted to raise this question. As actually, 20 years ago, there was an article in Times of India that as far as blindness in diabetes is concerned, none of the patients have been educated that their eyes may be affected with diabetes. That was the main reason why, a lot of diabetic have retinopathy, which went on, into a proliferative stage, never been diagnosed in the early stages because they never presented to the ophthalmologist. That's first thing. And the second question is, whenever we refer a patient, to an ophthalmologist, actually, majority of the time, we are not getting the retinal exam findings as such. Previously you mentioned about doing a retinal exam with a dilated pupil. And majority of them, they come with, some sort of refractive glasses. And then and they think that they have done, once they have the refractive glasses, I think they're done with it, because most of them are not told about the retinal involvement in diabetes. And I can tell you a lot of cases wherein patients got the cataract surgery done. And then after that, they say that surgery has failed. But I believe that, there may be a retinal element which has been missed before. And then patients should be educated that, doing a cataract surgery, you should mention that there is another way, another method wherein you can have to attend the ophthalmologist again to get their retina checked, because that may be the reason why they're having, less visual acuity, even in spite of having a cataract surgery done. I think if you can comment on this, I think I'd be glad, man.
Yeah, certainly, sir. Yeah. So this kind of situations, they happen more commonly at small centers and all, wherein there is not much public awareness. And also, which is why I have mentioned that even in the waiting hall area, also they're supposed to put a lot of posters mentioning about the dilated retinal examination and the complications of diabetes that is occurring into the eye, which is not only in ophthal clinics, but also even in general at a physician's or any health center, along with, other posters. Even diabetic retinopathy also should be placed. It all brings about how public awareness and how people are educated. And even at ophthalmology clinics also, where, a proper dilated examination has to be done prior to a cataract surgery.
Okay, thank you, madam. Thank you. I think, as far as the patient education is concerned, I think as you mentioned about the physicians' clinics, I think, in other clinics also you have to place this because the
Yes.
diabetics can attend various other clinics.
Yeah, yeah.
And then I think it should be a universal, through some sort of an IMA. I think, you have to reach the patients because, we come across a lot of people who say that they can't see anything.
Yeah.
But, and they got the cataract surgery done 5 years ago. That's what they will tell. And they think, once cataract surgery is done and then they have blindness,
Yeah.
that's their fate. They don't realize. And I don't think many of them have been educated by the ophthalmologists also. Nothing against you particularly, but I say that I come across a lot of patients. The ophthalmologist never told them to come back again to visit, to get their retina checked. I think, it has to go in your field as well as far as, patient education is concerned.
No, but even in patient perspective point of view, also they are quite reluctant. They consider eye to be like nothing at all. Like they just get cataract, they just run away. Even if the proper advice is given, they don't usually recommend. I mean, they don't get it done. So
Okay.
a lot of patient education also is supposed to be done actually.
Okay. Yeah. Thank you, madam. Thank you.
Thank you.
Thanks a lot, ma'am. Thanks a
Hello.
lot, sir, for the
Hello, ma'am.
valuable observation and the situation currently which is running in the diabetic retinopathy. Recently, yesterday, I have seen a patient who has got cataract surgery 4 months back. He is not improving. When I have checked, he is having macular ischemia. Macular ischemia will never come within 2 or 3 months. So he must be having long-term proliferative diabetic retinopathy or long-term diabetic macular edema, which was untreated. So before the cataract surgery, if the fundus could not be seen, at least after cataract surgery, fundus should be seen thoroughly. Thanks a lot, sir. So just a small information. That's why I have made on Thursdays diabetic retinopathy screening for free at my clinic. But though so many patients, they will be like, ma'am, is it necessary for dilated exam? Then I'll be like, this is the reason I have called you. I want you to check. Thank you, sir.
Thank you.
Srinivas sir, you can ask your question.
Hello, madam. The thing is, here we see a lot of diabetic patients, madam. The thing is, the patients are not. That is one thing is they are not aware about the diabetic retinopathy. The other thing is the patients are very poor to go to ophthalmologist and check the fundus examination. So regularly we'll be saying about the. So diabetes affects the eye, brain, heart, and kidney and blood vessels. We regularly tell them, and we tell them to. So heart and all we'll see, but the fundus we are unable to see. And the other thing is, the patients are very poor to go for ophthalmologist and have fundus examination. So even though Nalgonda Provincial is offering free diabetic retina checkup, I regularly tell the patients, but they are not go there. So is there any other method so that we can screen the patient for diabetic retinopathy in the physician office?
In Arogyashri scheme, there is this about diabetic retinopathy and free injections that can be given. And also, according to the Indian government, also they have launched this new scheme and the OCT scan also. So with these two schemes, I think even the non-affordable patients also can use of it.
ఫస్ట్ డే అనుకుంటా నాన్న ఫస్ట్ డే అనుకుంటా కదా నాన్న మొత్తం గోల గోల ఉంది నాన్న తర్వాత ఎప్పుడన్నా వద్దాం
Hello, madam.
Yeah, sir. Yeah, so I feel with the Arogyashri schemes and with the Pradhan Yojana program, so with that, even the non-affordable patients also, they can receive screening to an extent, and in Arogyashri also, wherein they receive injections also for free. So, and to an extent, even retinal photocoagulation, the laser also is given free for really non-affordable patients. So they can get it done.
So vascular endothelial factor also is given freely, madam. Vascular endothelial proliferative factor also is given free of cost.
So I didn't get you. I didn't hear you, sir. What's that?
Vascular endothelial growth factor also is given free of cost, madam.
Yes, yeah. But
Under
the recently launched anti-VEGF drugs, but the most bevacizumab drug has been given for free of cost, not ranibizumab or aflibercept and all. That's pretty patients have to buy for that.
Madam,
Right.
this one, when once diagnosed, type 2 diabetes diagnosed first time and type 1 diabetes diagnosed first one, what is the period we have to check for diabetic retinopathy, madam?
So once if they are newly diagnosed with diabetes, I would recommend them to screen for diabetic retinopathy screening immediately. And from then on, yearly once, depending upon the severity in the retina. Because we don't know that they've been diagnosed diabetes for the first time, but they may be having high sugar levels from past couple of months, which was not detected earlier. So whenever they are diagnosed with diabetes, they have to come up for screening immediately. And from then on, based on severity, we can take over.
Namaste,
Thank you,
madam.
Namaste, sir.
Hello. Madam, problem is we are detecting regularly, we are seeing diabetic cases and we are sending to the ophthalmologist. And we are also encouraging the patient to go and check up the eye checkup. But the problem is most of what the ophthalmologists are doing, they are encircling one round and they are the problem is sometimes he is unable to do which one is superior retinal artery, which one is inferior retinal artery, where is the retina, where is the fovea. There is a problem. Some retina. We never understand what is the whether it is retinopathy or non-proliferative or proliferative. There are all these problems are there, madam.
No, so in a well-organized setup, what we usually do,
Organized setup means in this
write it
setup,
down all the
Nalgonda, we are
features.
having ophthalmologist. Of course, there are some sending some printed matter. What is called as some fovea and red color, retinal arteries, all these things. But they are not at least marking where is the dots, blots, and all the flame hemorrhages are there as a proliferative or non-proliferative.
There is actually a color coding system which is to be done, wherein the hemorrhages which are there are coded in red. Then if there is any other axonal stasis which are represented in yellow, macula is represented in a red cross. There are different colors which we represent while drawing the fundus examination.
See, it is the job of the ophthalmologist, madam, whether a patient is having retinopathy or not. At least you have to write in detail, then we will alert now. Most of them are what are they are doing, only they are encircling some and they are writing, we are unable to because of a heavy schedule. Most of them are doing like this.
Yeah.
So most of the patients are, we are unable to concentrate whether really this fellow is having retinopathy or not. We are unable to detect. Then there is a problem of he is progressing the final stage. That is a very problem we are facing, madam. So anyhow, we are doing and we are concentrating on there is a tight glycemic control.
So in such conditions, I would rather advise them to go for a fundus camera picture, so that it is beneficial for patient and for both the physician and ophthalmologist to have a clear picture. If it is difficulty in if somebody is not unable to understand what is written in the paper, I think by the fundus camera picture is brings more clarity.
Good evening, Dr. Kaveri from Puducherry.
Okay, good evening, good evening. Very nice.
Thanks for
As
joining
usual.
our webinar. And do you have any questions or any suggestions?
No, as a diabetologist, I was very happy that you have conducted this session, because she has given in the epidemiology slides from 2.3, it is increased to 25. And this is a very alarming thing, because it is time that we create the awareness among our public. The previous doctor was telling that he is sending cases and they are not coming back with proper things. Yes, it is the beginning. Whatever you are doing is great, and we should improve upon it, which you are doing. And I think all over the country, people will come to create this awareness, because this is becoming really alarming. 25% people going into retinopathy. I'm very happy with whatever webinars you are conducting, Dr. Vasantha. Very useful and wonderful that doctor has presented a wonderful chart, very crisp and nice. My congratulations to all of you.
Thank you.
Bye bye.
Thank you. Thank you. And I appreciate Dr. Pranusha's service. She has just started her clinic recently and she is doing free service because people are not aware of retinopathy.
Very good.
Congratulations, Pranusha.
Thanks a lot, ma'am. Thanks a lot for your encouragement.
And
Sorry for the interruption, ma'am. Yeah. So, Dr. Matru, sir, if you have any doubts with the fundus pictures or if you have anything, you can definitely contact us, sir. You can definitely send the patient to any retina specialist. Definitely, we will do the color coding, sir. If the patient is having hemorrhages, if the patient is having cotton wool spots or microaneurysms, it is a dictum to color code it, sir. We will definitely do it with the macular edema also. We will mention it. I usually see diabetic patients still ora serrata.
Madam, I'm not blaming anybody. Only thing is because of heavy schedule, because of busy schedule, most of them are doctors are. So we are unable to concentrate and most of them patients are going to the end stage. That is my problem. Okay. So
Yes, sir,
most
thank
of somebody is writing, we don't understand. Somebody is what he written. So because of these all busy schedule, you just write whether it is a DP, progressive or non-progressive retinopathy, then it is end. That is my point of view. Otherwise, I don't want to blame anybody, madam. Okay.
okay, there's one more question from Dr. V. Sudhakar. He's a pediatrician. That when to screen type 1 diabetes children.
Yeah, I have mentioned that according to the guidelines of the pediatric group, they have mentioned that after 11 years of age, it's better to screen the children for diabetic retinopathy.
Thank you. Many physicians have joined Dr. Kavya.
Good evening, madam. Can I give you a suggestion?
Yes, yes, sir.
Yeah,
Introduce
see, I'm Dr. Rajshekar Reddy. Actually, diabetes being a microvascular disease, actually, if someone presents to a clinic with a deranged renal function, like, abnormal creatinine, or having some sort of a coronary symptoms, then probably these are the patients because the retina is most likely to be involved in these patients. And whenever someone has some end organ damage, I think the physician should educate the patient that they have to get their eyes checked as well. Because as we all know, diabetes is a microvascular disease. It can affect any organ. But if there is evidence of one organ getting involved, I think it's better, that patient be referred to an ophthalmologist for a thorough retinal exam.
Yes, totally agree with you, sir. They have to send, it's a universal, like, all the doctors have to come together and have to get each and every organ checked, let it be a physician or a pediatrician or a gynecologist. The screening for diabetic retinopathy is a must.
So the other thing, madam, the other thing is once retina is involved, all other organs is almost involved. That is the rule. Diabetes. Once retina is involved, all organs are involved.
Yeah.
Incidence of retinopathy is more than nephropathy, sir.
Yes.
No, that's what, Pranusha. I think someone comes to you with abnormal creatinine, it becomes the duty of the physician to refer them to a ophthalmologist because, if they catch you in an early stage of diabetic retinopathy, probably something could be done, I think as far as the blindness is concerned, it is alarming because as I mentioned before, a lot of patients come to me saying that they can't see much, their visual acuity is limited. But they would always quote that, they had a surgery done 2 years ago for cataract or something like that. They are not aware that there is another, organ called retina, which is causing these problems. I think, it has to be a wholehearted and a holistic approach of all the physicians and the doctors concerned. I think you have to educate the public. I think, the cataract may be the major cause of blindness, but over a period of time, I think diabetic retinopathy will overtake cataract as a major cause of blindness if you don't put in an effort to educate the people and then make efforts to get them checked thoroughly by ophthalmologist.
Yes, totally agree with you. And also there are certain patients who, in spite of educating them, still they're being very reluctant because for them, if it's blindness, it's only cataract. So it is nothing beyond that. So even if you educate them for retina, they are they stick like adamancy and they don't want to get retina examination done also. So there are those set of patients which need thorough counseling and repeated encouragement for them to get a retina check done.
The other thing is, madam, behind the retina also one more organ is there. That is occipital lobe also is there. Here blindness can be there. So there are serious ways are there. Once retina may be normal, but occipital lobe also could be involved. Where diabetes could be the cause, where bilateral occipital lobe involvement is also one of the cause of blindness.
Yeah.
Same diabetes.
Yeah.
Diabetes retinopathy after the cataract, how to follow up, madam?
So
After getting the
prior
cataract
to-
surgery in diabetic patients, how to follow up? What would be the symptoms of early stages of retinopathy to the patient?
So usually if the patient has a cataract, and then it is definitely to get a retina check done. Now in the cataract patients, if it is in early stages of cataract and vision is still further improving, then we can wait for the cataract and then get a diabetic retinopathy screening every 6 to 12 months basing on severity of the cataract. But then if the cataract is progressing, and along with that, even the diabetic retinopathy changes are also progressing, then in such cases, if there is any edema or if there is any neovascularization, better to plan at least prior to cataract, at least one dose of anti-VEGF injection or one setting of PRP laser to be done. Plan for cataract surgery, and post cataract surgery after 2 weeks, again, review back to the retina check to examine for the edema status or the neovascularization status. So even after cataract also, basing on the severity inside, either the monthly checks or a 4-monthly checks that has to be done. Or if it has a neovascularization after cataract surgery, finish the next 2 sessions. So the coverage of VEGF fluid will be done.
Thank you. There is a lot appreciation from Dr. Indira Devi, madam, our senior gynecologist. Madam's suggestion is many may not be aware, just come for eye checkup. Can we have camps like for cataract for high risk? And from Dr. Venkat, we can have camps. Yeah, we would like to have eye camps provided all of they are very cooperative, our physicians as well as ophthalmologists. We have conducted several times diabetes camps. I was very new to IMA then. For the first camp, we have had 250 members for diabetes camp. Out of 250, 10 members were detected something or the other complications in eye. Then two were two had glaucoma, silent loss of vision. So camps are really in need in rural areas. That is what I feel. Pranusha, we encourage you to conduct.
Definitely, ma'am.
If there are no more doubts, can we conclude? Dr. Sampath, are you available?
Yes, I am available.
Yeah. Your remarks regarding the webinar and in future webinars and your suggestions are invited, sir.
Okay, and here today's lecture was very good because in a short duration, Dr. Kavya Rao has covered the entire topic, and she has also informed about the latest developments and screening methods and also the treatment modalities which are available. And there was a very good interaction from all the participants. So that is also a very good thing because interactions will definitely help not only in enhancing our knowledge, but it will also help us to take precautions when patients with such problems come to the doctor. And I'm very happy that this sort of interaction has taken place. And as there has been a lot of discussion, I think we have to, there may be some protocols, but still we should have some protocols where the patient who has been diagnosed with diabetes, we have to, at certain intervals, already the speaker has mentioned about annual screening for the retinopathy. Similarly, we should have some screening methods for other complications. As one of the doctors has clearly pointed out, a person who is having high levels, slightly elevated levels of creatinine, then that patient has to be sent to the ophthalmologist. The other way around also, diabetic retinopathy, patient with diabetic retinopathy, the ophthalmologist will always ask the patient to get his renal functions also checked and go to a nephrologist. So all these are interlinked, because as the duration of diabetes increases, the incidence of complications and the disease progression is seen. So it is everything is interlinked, but basic thing is most of us will be concentrating on the control of the diabetes. So we'll looking after the glycemic control and the HbA1c controls. Apart from that, we should also think of referring the patient to the concerned specialist. And the other way around also, what one of the doctor was pointing out, after the patient is referred to the specialist, they also have to send the patient back with the clear-cut findings or whatever their interpretation is there. And now this photograph also is being mentioned, so that we have a clear color code to know what is the problem. Anyhow, the interaction is helping us to know how we should proceed and what else we should do in future, so that we can detect the problems at an early stage. As you already mentioned, you have conducted eye camps for diabetes camps, and in such camps, with the help of the ophthalmologist, you are also able to detect diabetic retinopathy and also glaucoma. So all these things are very much interlinked. So I think the CME is very important so that we have exchange of ideas. Plus, we can also help the patients in early diagnosis. So most important is to refer the patient or screen the patient at an early stage. And once the patient comes, they may come to us after a very long time, but still we have to remind them. I know there are a few doctors who remind the patient, who call the patients if they are not coming to them for a review, especially the patients with diabetes. If they are not coming back for a review at regular interval to the doctor, there are some doctors who call them back or send them SMS messages, all those things. That is all good, but all of us should see that the incidence of diabetes, diabetic retinopathy, or any other complication due to diabetes is decreased, because we know that India is slowly becoming the capital of diabetes in the world. Of course, China is leading, but we are probably second. And coming to our own state, Hyderabad is supposed to be the capital of diabetes. So it is important that the lifestyle management and control of diabetes all take place, along with the prevention of complications, early detection of complications, and appropriate treatment whenever the complication is detected by referring to the concerned specialist. I thank all the participants for their interaction with the speaker. And it's very important that participants should actively involve in the interaction. I thank the speaker. I thank the group of doctors behind the speaker, and also Dr. Vasantha Kumari for selecting this particular topic for today's discussion. I thank all the participants, who include physicians, pediatricians, and senior consultants, and also a diabetologist from Chennai. So this gives us a lot of encouragement so that we go ahead with many more topics which are of use to the doctors, general practitioners, and even the specialists. Thank you very much to all of you. Thank you very much, madam.
Thank you.
Thank you, sir.
Thank you, Dr. Kaveri.
Hi, ma'am. Thank you.
Yeah, right.
I will attend all your sessions.
Thank you very much. Thank you, Anand sir. Thank you, Srinivas sir. Thank you, Matru. Thank you, Dr. Sudhakar. All physicians and
Thank you very much.
family physicians join here. And I'm happy, very happy for active interaction.
Yeah, thank you so much.
Thank you. Thank you. Good night. We'll end the session. Thank you.
Okay, thank you, ma'am.
Thank you, ma'am.
Thank you, Dr. Kavya.
Yeah, thank you. Thank you so much, madam, for the opportunity. Thank you.
Thank you, Indra madam, for joining and encouraging all the sessions, madam.